Welcome to Baby Snugs and Coffee Mugs. I'm Krista.
And I'm Kelsey. We're both labor and delivery nurses from Minnesota. In this podcast, we'll be covering all things pregnancy, delivering in a hospital, and caring for yourself and baby postpartum.
This podcast is meant for educational and entertainment purposes only, so please seek medical advice from your healthcare provider. We are so excited for you to join us, so grab your coffee, snuggle up, and keep on listening.
Cheers!
Cheers! Welcome back, everybody, to episode 13 of Snugs and Mugs.
Welcome, everyone. This week we are going to talk low intervention labor, meaning that you are going unmedicated during your labor. A few weeks back, we talked about having an epidural during your labor and every step of that. We want to do the exact same thing this week and just give you a little bit more information on what you can expect being low intervention.
Exactly. So really, guys, the best thing you can do for yourself going into planning an unmedicated labor and delivery is be prepared. So do your research, mentally prepare yourself to go through excruciating pain, knowing there's other options available, but convincing yourself that this is what you want and this is what you want to do. And honestly, I feel like my patients that do the best personally are the ones that have prepared themselves and done classes and done research and have stuff in place for when they do get really uncomfortable and their brain starts thinking that way. They're like, nope, I'm not getting one. This is what I want. This is what I'm doing. And it's kind of a lot of self-control and when you feel really out of control of your body.
Yeah, I don't think I can reiterate it enough. Exactly everything you just said. You have to mentally prepare.
Yeah.
And you can do it. I promise you can do it. I've seen it happen.
Yeah, it definitely happens a lot. But the ones that we see that really make it through, that don't come in and just spit out a baby, they're really prepared and they really know all their options and know what they can use to help themselves get through the pain.
Exactly. So that is, our hope is to talk you through all these different opportunities that you have to get yourself to the end.
Exactly. So let's just start this off. So you guys are at home and you are starting to feel contractions and you're starting to go into labor. I think that the best case for you is to stay at home as long as possible. You're in your comfort space, you have your bed, you have your own bathroom, you have your own snacks. You're in your place where you feel comfortable and you are going to feel the best at home versus how you're going to feel once you're in a hospital environment. So if that is your plan, please try to stay home as long as possible with obviously there's some things here and there that's going to tweak that plan. But you have a much better chance of staying unmedicated if you're at home where you can't get medicine.
100%.
You don't have the option.
Yeah, definitely. So again, you are comfortable there. That is where you are going to be able to rest, where you're going to be able to concentrate a little more. There's not other things happening around you. Mm-hmm. I agree. But like you said, there are reasons that you can't stay at home for a long time. A couple of them, we have talked about it multiple times. Your GBS status, if you are GBS positive, you do need antibiotics in your labor to help protect baby coming through your vaginal canal. Mm-hmm. And then as a reminder, those antibiotics have to be in for 4 hours for it to be deemed treated.
Right.
So keep that in mind. If you know you're GBS positive, make sure you come in. Another thing, if you have had a history of a fast labor, you had a baby super quick your first round or your second round, whatever that last baby was, come in probably sooner rather than later. You're not be having a baby in a car.
Yeah, no, I mean, they make great TikToks. But other than that, guys, you do not want to have your baby in the car. Like, obviously, that's not your plan if you're planning to deliver at the hospital. So if this is you and most likely your provider's telling you this in the clinic, they'll know your history. Just come in. Come in sooner. This doesn't pertain to you. Don't stay at home.
Yep. Another thing is if you live far away, if you're in a rural area, if you have a high traffic area, those are all reasons if you're going to be in a car for an hour.
Yeah, that's a good point. Yeah, I had a
Come on
ride.
in.
I didn't even have to think about it. So yeah, if you have an hour ride, guys, keep that into consideration.
Yeah.
Sure.
And then one last thing is if you feel like your water has broke. Once your water breaks, you can be more at risk for infection. So come on in so we can kind of monitor that a little closer too.
Exactly. So say it's time for you to head into the hospital for whatever reason it is. But what's that admission process going to look like? Again, like Kelsey said, we did discuss some of these things in our other episodes that have talked about labor. But the initial kind of assessment of you guys is fairly similar. So when you guys get there, we're going to do a first off overall head to toe assessment. We're going to get your vital signs. We're going to put the baby on the monitor. Most women who are planning to go unmedicated don't want the monitors on, but we do really need that initial, what we do is 20 minutes, and we're looking for a reactive baby. So we really want baby to look good, to make sure that their heart rate's not dipping and that they're tolerating the contractions that you're having at this point. So we typically put people on for 20 minutes, and if they are looking okay, the baby looks okay, the mom's doing okay, you can come off of the monitors at that point.
Yeah, we call that a reactive NST. So if that is what your nurse is telling you that we're wanting it, that's the reason why. And you actually might even hear about that in clinic too. I think people get monitored in clinic looking for that as well.
And I think this is a good thing to ask ahead of time too, just so you're kind of like mentally prepared. Because obviously there are a little bit of limits when you're hooked up to monitors. For us, you can only go so far. We have portable monitors that work too, but not everywhere has those. So if you do have to have that chunk of monitoring done when you initially arrive at the hospital, it is good to know to mentally prepare yourself. So that is a good question to ask in clinic, like kind of what their policy is around that, just so you guys are ready for it. So we have the baby on the monitor. We will do a cervical exam at this point, just kind of see where you guys are at. There are times where patients aren't wanting their cervix checked quite right away. If you are in active labor and are really uncomfortable, this is okay at this point. But most often than not, I would say we probably check people's cervix. And honestly, a lot of people would just rather know.
Yeah.
At least the patients I get.
I agree.
And then the last thing we're going to do in this initial kind of assessment area is we're going to place an IV in. For most unmedicated patients, we don't really use your IV very often or if at all during labor. But it is for emergency use. The first thing we're going to do if the baby's looking like it needs some help from our end is we're going to give you some fluids, and that's going to go through your IV. It just is really quick to get to the baby versus if you're trying to drink and if you're nauseous and you can't drink, it's a lot easier for us to do it that way. Also, it's for emergencies. Unfortunately, you just never know when an emergent situation is going to pop up, and we already have that in place, so if we are to need it, it's right there. So during that kind of time set, I guess, I feel like things kind of go really quick. That 20 minutes kind of goes really quick. And hopefully you're coming off the monitor at that point. But I usually find this the best time to discuss birth preferences with my patient. Do you too?
Yeah. If a patient's being admitted, especially if they bring in that birth preference and that sheet, and I am reading through it, I am going over it with them. I am asking like, what's the most important thing on this to you, or multiple things? Is there anything outside of this that you want me to know? Who is involved in your care? Who did you bring with you? Did you bring your support person? Is that your husband? Is that your sister, your friend? Did you bring a doula? Have you guys talked about what role they're going to play today?
Yeah, that's a big one. I think everyone's just a little different, and I always try to ask my patients, I'm like, what do you want from me specifically? I've had patients that I haven't left the room besides a bathroom break, and I've had patients that are kind of like, yeah, so we kind of got our own thing going on, and like, you can come in and check on the baby, and then other than that, we don't really need you, and that's okay too. We are there to do whatever you guys want us to do.
Yeah.
I always just ask, because I don't know what you are thinking, so I'd rather just kind of chat all of it through as long as we're able to, in between contractions, sneak those conversations in. So I kind of know like what you want of me, what you want of the midwife if you have a midwife, or the provider that's there, and kind of the expectation you have for your support. So what are you expecting your doula to do? Like, what's your plan so that I don't try to do the same things the doula is doing? Or what do you want your significant other or your whoever the other support is, what do you want them to be doing? It's kind of nice to just kind of get that laid out so we just don't have to think about it going forward.
I was going to say, it's awesome that you ask right off the bat. I think sometimes I do. I don't always think about it, but a lot of times I'm just trying to read my patient on what I feel like they want. But I just want you guys to know, like, we're never offended if you tell us that you don't want us around.
No, not at all.
Totally fine with that. I have had patients that, it's just they're in their support person and they do everything, and I honestly just feel like I'm in their way.
Yeah.
And then other times I just feel like I'm reading it that they want me there and need me there. But if that's not the case, just let us know. It's okay.
Yeah, exactly.
Or if you need us more, tell us to get our butts back there.
Yeah, that's fine too. Yeah, say like, you know what, I changed my mind and I don't want you to come in every half hour. I need you to stay in here because what you're doing is working, or I just like to see your face. I had one patient, oh my gosh, it was so cute. I was gonna go get something and she just panicked. She's like, don't leave me. And I was like, oh, I was just gonna run and get something. And her husband's like, what about me? She's like, I don't need you, I need her. It was so funny. But yeah, that was just the dynamic in that room specifically. Yeah. But yeah, so we're not offended. We just want to know what you guys want. So at this point, we did those 20 minutes, guys, and we're talking about your birth preferences, and then we are going to kind of see where you are in the labor process. So most likely our cervical exam is going to kind of tell us where you're at, but also your contraction pattern and the amount of pain that you're in. So there are kind of obviously two options, I guess three. You could be ready to push and have the baby, but you could be in early labor and you could be in active labor. We can kind of run through some things of what we think is helpful and is best for each of those, starting with early labor.
Yeah, let's talk early labor first. So early labor, I think, is typically less than like 5 centimeters. You're contracting, but you're doing okay with your contractions. You can still have a conversation through them, or maybe it's taking a little bit of time to breathe through them. All normal. Yep. During this time, we are offering you a couple different things. First things, you can rest. If you feel like you can rest through them or sleep through them or between them, this is a great time to do that.
Yeah, sometimes it's the middle of the night.
Yeah, exactly. And you need to conserve that energy for what's about to happen. Other things, walking is a great thing. You want to get your body into active labor. So moving, walking, start doing some lunges or squats, whatever that is, we want your body to keep progressing naturally. Yeah. So those are a couple of options. We have birthing balls at our facility, so bouncing on a ball. You can rock on the ball if that's comfortable. There's multiple positions that we are going to try and offer that are comfortable for you.
Yeah. And then snacking. I always tell my patients, they're usually not nauseous in early labor, I would say. More often than not. Get some calories in you, get some energy by eating, because most likely in a little bit you are not going to want to eat.
Or you're throwing up. One or the other.
Throwing up. So yeah, I guess keep that in mind too. Kelsey makes such a good point. Whatever you're eating, you could potentially throw up later. So kind of think about that. Do you really want to hit the Taco Bell on the way down? I would not.
Okay, so let's say lighter snacks.
So kind of put that into consideration when you're deciding what snacks you want.
Yeah, and then during early labor, we will still be monitoring baby. I know we kind of touched on getting that initial reading of baby, but we're going to be checking in on baby hourly with our DOP tones at this point too. So
yep, that's the same thing they use in the clinic just to check the baby's heart rate, and we always check before, during, and after contraction. And what we are looking for specifically is to see if the baby's heart rate makes any increases or decreases. So typically increases are a great sign of a neurological response that we like to see. But any dips or having a heart rate that's really low would be concerning to us. Sometimes it could be your positioning, sometimes it could be a fluke, and sometimes it really could be that the baby's kind of in a little bit of distress. If that is the case, then we will put you on the actual monitor versus the DOP tone and just ensure what we thought we heard, make sure baby's doing okay. But other than that, as long as baby's tolerating it, which typically is what's going on, at this point it's that every hour.
Yeah, awesome. So you are getting through early labor just fine, and you are starting to turn into active labor, which means you are hitting 6 centimeters. You are getting way more painful. And
just amping up.
We got other options for you.
So I think that the biggest help that I have for my patients in active labor is the tub.
It's my number one thing I recommend.
I always fill up the tub. They get there, that's their plan. I'm like, let's fill up the tub and get it ready. Because one, it takes forever to fill up because they're big. But also, then it's there and readily available when they want it.
And I do save it for active labor.
Yes.
I do. Yep. I think it's one of the better distractions you can have. And I feel like people have the most relief from it, that I absolutely want to save it for you when you're at your most uncomfortable.
Yes, exactly. So tub, number one thing. Hopefully where you're at has a tub, or the option for a tub, or a room that has a tub, because that's going to be your best friend.
Or shower.
Or the shower, yeah. Not everyone's a tub person. We have shower chairs, so you can still, I've had patients that, sit on a shower chair and just have the hot water kind of going on their lower back if they're having back pain, or kind of on their tummy. I've seen people use the shower, too. That's a good point. Birthing balls. Birthing balls are great throughout all of labor. So if you use that birthing ball in early labor and really liked it, keep trying it through your active labor, and 9 chances out of 10, it's probably still going to be really, really good and really helpful for you. breathing techniques. This is one of the really big things that you're going to have to go in like practicing and knowing, and do not listen to movies because you do not want to breathe like that. You're going to like hyperventilate. So watching YouTube videos or something, talking to your midwife, your provider, whoever it is, about the best breathing techniques kind of help you get through the contraction. And then in between contractions, rest every little ounce of your body, because it is so easy to like hold so much tension because you are going through a lot of pain, as we have talked about. So we can kind of help you with that. I feel like I often remind my patients to relax their eyebrows. Their eyebrows are always just hold so much tension. You can just see them like almost like furrowing their brow because they just can't let go of all that pain. And so even if I'm like in a room that's really chill and quiet, I'm always like, relax your eyebrows, relax your eyebrows. And then you can see their face just calm down, and you can kind of get them into that calm state in between their contractions.
Yeah, I think like the number one thing that I am constantly telling patients is to breathe.
Yeah.
So please don't forget to breathe. I think the number one thing when you are in pain, you want to hold your breath.
Yeah.
It is just a natural
Even with
response.
practice, you want to hold your breath.
Yeah, absolutely. So, if we're saying to breathe, it's because we actually want you to breathe.
You need oxygen. So with these breathing techniques, also we want to find a good position for you to be in. With that being said, every position is going to hurt, okay? I don't want you to think that like one position's like, oh my gosh,
Magic.
this feels great. Like
Yeah.
it's all going to hurt. It's all going to not feel great. But you're going to hopefully find one or maybe a handful of positions that feel better than the others. Like I've had patients that cannot, like when they sit down, they're like, it just hurts 10 times worse. Like I have to be moving. I cannot sit still. And then I've had the opposite where they're like, as soon as I start walking, like it just hurts 10 times worse. Like I just have to like be still in whatever position I am. So just kind of finding what works for you for your comfort. We can do what is called counter pressure. So just a little bit ago I mentioned back labor or back pain. I use this often when my patients have back pain. I always put them on the ball. I have them lean forward so that head gets away from their back, and I press on the lower part of their back while they're having the contraction. So if you guys kind of think of the muscles inside your body as those are squeezing towards your back because everything's tightening, if you put pressure and kind of counteract that, it can feel really comfortable for the mom. So it could be your back, it could be your hips. Everyone's a little different where they like that counter pressure.
Yep.
But we can try a few things out, and it's a good spot for the support person to be because I have weak arms and I can only last pressing on your back for so long. So
Yeah.
we can take turns. It's great.
Yeah. And so pressing on the back, my other favorite one is squeezing hips together. So as you are getting a lot of pressure, you are feeling like you are ripping apart, I have heard people say. So pushing those hips together will help kind of relieve that too. Like Krista said, you might not like it. Tell us to stop and we will.
Yeah.
We will find a different type of counter pressure. Another one of my favorite ones that was so random, a midwife taught me it, is when you are laying in bed or sitting in bed, you can put your knees up and we push on your knees. For whatever reason, it is, I don't remember what the reason behind the counter pressure was, but I feel like that has been successful with a lot of patients.
Nice. Yeah, I haven't tried that one. I'll have to use that one next. So counter pressure can be super, super beneficial. And then any sort of distraction tool that you can have. I know like we have like a bin full of things. We have those little spiky looking balls that you can squeeze, or a comb.
Like a stress ball.
Yep, like a stress ball. Anything that you can use to literally give yourself pain and distract yourself from the other pain that you are having. If you heard Kelsey's dog just ignore
So
her.
sorry.
So any of those things I think are super helpful. And then we also have like a handful of massage devices. So like a roller for the back, like I've used that on a back, or like an actual vibrating one. I've used that on patients' lower backs. So it's kind of dependent on one, what you think works for you, but also what your facility has. So add this on to the list of questions you are asking your provider before you go into labor is, what do you guys have for me to use while I'm in labor? And then potentially you can, I don't know, find a friend that had one, Facebook Marketplace, hopefully find them cheap or something, so you don't have to buy a bunch of stuff if they don't have options for you. But I would assume if we have a handful of options, most places probably do too.
Yeah, for sure. Few other things that we can do for you in labor to kind of just help you get through this. I always recommend turning off the lights, dimming lights, whether you just have a little lamp on, if you want to bring in like fake candles, it just sets a mood. It is a calming environment. It is going to help you relax, especially between those contractions. I love a calm, dim room.
I do that too. You know, working straight nights, obviously it's dark outside, but I like even getting my rooms ready, I put like one little lamp on, and now we have like with dimmable lights, I like have them way, way low. So I'm like, once maybe it's time for delivery, we might pop them on, guys.
Yeah.
But for now, yes, Kelsey is so right. Please keep your lights just dim, and like the calmer you can keep your environment, the calmer you're gonna be. Yeah, good point.
Essential oils, another favorite. Check with your facility to see if they have them. We provide them where we work. I love putting them in the tub
Yeah.
when you're in active labor. We have specific essential oils that are like made up and mixed. So I feel like they are successful.
Yeah,
I couldn't tell you.
Blend, my
Yeah.
favorite.
I
put
swear
in
it
the tub
works.
all the time. Either that, or I do like the foot massage. I make the dad or the significant other, whoever, somebody else. I'm not usually a foot person, but like massage their feet with the transition blend. I swear it weirdly works. I don't know.
I mean, convince you get a foot rub out of this now,
Yeah,
guys.
that's true. Yeah. Might as well try it just in case.
Yeah. And then if your facility doesn't have it, just bring some in, whatever your favorite is. Peppermint oil is really good for nausea. Lavender is really good for calming. Just kind of look those up and see what you think you might need.
Oh, and then what else you guys should do is make a playlist. If you are a music person, everybody like feels calm from different things. If you are a music person, have a playlist ready. One, I'm the type of person, if I'm listening to music and an annoying song comes on, I'm just annoyed, right? Like I'm like, oh, skip, skip, skip. You don't want to be doing that while you're in labor, right? So make a playlist, have that set and ready, and it can be calming music, it can be pump up music. You can have multiple playlists. It's just like such an easy distraction tool and helpful like mind setting tool for you, especially if you are listening to music that you feel a certain way about. You know what I mean? So yeah, I've had a lot of patients come in with playlists.
And I've had it from like every type of music.
Yeah.
Like country, rock.
Yeah.
Again, some like calming meditation.
Yeah.
Have at it.
Different. Yeah. I've actually had one person that brought in like a little clip of her significant other like talking to her, and like so that he didn't actually have to like in the moment say stuff to her.
Yeah.
Because I don't know, it's kind of high pressure. If
That's
your
so
significant
cool.
other is like so uncomfortable. So he kind of had this thing, and like it wasn't on a loop. So like it would be song, 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 and then it would be him like, "You're doing great. Keep breathing." And it was like little like snippets of encouragement. It was actually really, really cute.
That is so cool.
Yeah.
I have not had that happen.
I've only had it happen once, but like I don't know, it's a great idea, and I thought that was really cute.
Yeah.
Cute enough that I brought it up. So, so yeah, that kind of wraps up all of our kind of tools that we have seen that we notice that are super, super helpful. And hopefully this is getting you guys to transition. We can talk about that.
Yeah, so you are starting to get real uncomfortable. Again, Krista talked about we'll check your cervix every once in a while. Not necessarily all the time. If you want to know what it is, have at it. But if you feel like you are wanting to start to push, a lot of times we will triple check that the cervix is all the way gone.
Yeah.
So meaning that you're 10 centimeters. And why we do that is because we don't want you to push against your cervix. It is going to cause swelling, and we are going to just prolong this entire process for you.
Yeah, a swollen cervix is stubborn, guys. So you definitely do not want that.
Nope. So that is one thing that we'll look for. But I would say there is a lot of things that tell us that you are now 10 centimeters and ready to push. I would say grunting is a huge one. Like if you say you're feeling pressure, great. That means we're close.
Yeah.
If it's like constant pressure, but then you start to grunt, I'm like, okay, we're there.
Yeah, your body just kind of like takes over, and like you get a look to you. Like there's a look
You
of
do.
transition that like the staff knows, the providers know, we know. Like it changes, and you are going to notice this change too. Like you're going to be like, something's different. That happened to my sister. We've talked about her second baby before and how she went with just IV pain meds. And she said, she's like, I was on the birthing ball and I looked at my nurse and was like, something's different. And she's like, okay, get in bed. And she's like, I don't think I can. And she's like, you can. And she's like, she got into bed and delivered like 3 minutes after that. I think she pushed twice. But like she knew. She was like, something changed so fast. Like it went from like this like feeling of pressure to like all of a sudden like it was overwhelming, like, oh my gosh, something's right there and I have to push. So you are going to feel it. We're going to probably notice that you are looking different. And if we can't see the head, it, as Kelsey said, is a good idea to just double check to make sure that cervix is all the way gone. So yeah, we can talk about pushing, I guess. We touched on pushing when we talked about laboring with an epidural. But obviously, this is a whole new ball game because you can move so much more, and you don't have an epidural, and you're not tied down to the bed, which is lovely. So finding a good position to push in can take a little bit, but it also can be really quick. If you just pop your baby out, you might just not even think about it. Your body might take over. You just find a position and time for baby. Doesn't always happen. We still have unmedicated patients that do push for an extended period of time. So we kind of want to still move positions and kind of try different things out. I think that my patients most often deliver on either their sides or their hands and knees when they're unmedicated.
Yeah, I would say hands and knees is probably the most common, but also I've had standing. I've had people that are the most comfortable on their back. A lot of people say that's not their most comfortable position, but I have had patients think that. So there is kind of endless options as long as they're in a safe spot.
Yeah, yep, as long as you're safe. We have this cool thing called a birthing stool. And it kind of, like, the best way I can describe is it, like, looks like a toilet seat. With
Kind of like a toddler seat.
Toilet.
Like a toddler toilet, but for an adult.
Yeah, basically. With an actual toilet. There's just, like, a hole there. And so, yeah, you can sit. It goes on the floor. You can push on that. We have a bar that kind of goes over the bottom half of our bed. The bottom halves of our beds drop down because it's a labor bed. It's meant to do that. And you can kind of sit, hold on to that. I've had people do tug of war, and we kind of talked about these things in our other one too, but basically you hold a sheet and you can either play tug of war with me or your significant other, whoever it may be, kind of using the force of pulling to help you push. I've done kind of all sorts of things with people when they've been unmedicated, honestly. You just have so many more options.
You do.
Than being kind of strapped down with that
Yeah.
epidural.
And again, we want to keep you moving with pushing if it's taking a little bit. So we're going to try out all these positions probably.
And we want that baby's head to navigate through that birth canal and down and out. So the more positions that we change you in, the better it is for that baby's head to kind of navigate his or her way down.
For sure. So then as baby is ready to deliver, we want you to kind of keep your ears open towards the provider that's delivering you, or maybe it's the nurse that's kind of trying to talk you through it. There are times that they want you to push a little harder, a little bit more quick, or they want you to slow it down and kind of breathe through it. And that is just protecting you, especially from like tearing is probably the number one reason we're doing that, or we're trying to make sure baby's safe.
Yeah, exactly. I am always amazed by the control that like women can have when the head is literally crowning and they're like, okay, you're gonna have to wait till the next contraction, and it hurts so bad, and they literally, you can just see it in their face that they just want to push so bad, but they're waiting for that contraction. They know that stretching is good for them, and they don't tear. And I'm like, how do you have that kind of, it is so amazing, you guys. I'm being nerdy right now, but seriously, like that kind of like literally mental control is just so cool to see. But yeah, as Kelsey said, typically they're trying to control the tearing and or help with baby. All right, so depending on where you guys deliver, if it's a side, if it's your back, first thing we're going to try to do is get baby skin to skin. So if your hands and knees, we kind of have to push baby up underneath you. You can grab onto the baby. However it might be, if you're standing, we might get you back in the bed. We want to get baby skin to skin with you as quickly as possible.
And then just remembering that baby's still connected to the cord, which is still in you, connected to your placenta. So we are being very careful with these movements. We are asking you to kind of like turn slowly or walk slowly. We're just trying not to like rip that cord off.
Yeah, definitely not. Yeah.
That would be an emergency situation.
So depending on exactly what happens, we are going to dry and stimulate the baby, kind of suck all those gubbers out of their nose and mouth. So it might be before they're on their chest. If you delivered hands and knees, it might be right away on your tummy if that's where they are. But that's kind of our way to make sure they kind of get some of those secretions out. And then we're going to wait for the cord to get cut. Hopefully in your birth preferences, you decided who is going to be the person to cut the cord. As a standard for us, we always do delayed cord clamping. So we will wait for that cord to be done pulsing, and once it is done, then we will clamp the cord, and then whoever is intended to cut it will get to cut it. Obviously there are times where we have to clamp and cut quickly if we need to bring the baby over to the warmer to kind of help baby out. But even then, I would say most often than not, our providers are good at getting that support person or whoever it might be to cut the cord.
Yeah, I agree. And I think our providers are also really good about checking in with you to make sure that they're okay at this time, as long as it's like not an emergent spot. But if that cord is done pulsing, like you said, they're still checking in and being like, is it okay that we do this now?
Yep, exactly.
Which is awesome.
So next step, cord gets cut, and then yay, baby gets all the way up skin to skin, right up onto your chest. So baby's chest to your chest, where hopefully they will be staying for at least the next hour, that first golden hour or the golden period that we've talked about before. And then while we are doing that, we are waiting for your placenta to deliver. As we talked in our other episode, it can take all the way up to a half hour for the placenta to come out. I would say with my unmedicated patients, the relief they get when that placenta is out and just like they know everything is done is like unbelievable. They're like, oh, thank goodness.
Yeah.
Like that is done. And then we are finally going to be using that IV that you guys have had in place this whole time. It is a standard at our facility to give you a bag of Pitocin that goes through your IV after you deliver. Obviously, there are times where delivery can get a little out of control and things happen and that IV dislodges. And if that is the case, we do have like an emergency IM or a intramuscular injection, so like a shot that we can give you guys. It's a lot lower of a dose, so that's not really the goal. We don't want to give that. But if we have to, we have things there if needed.
Yeah, so the point of the Pitocin after your placenta comes out, after you deliver, is to help contract that uterus down. It is preventing you from bleeding more than you already are. We are preventing what we call a postpartum hemorrhage. So you're going to get crampy, that uterus is going to contract, but it's what we want.
Yeah, it really, really helps. And then after placenta comes out, then it's time to see if you need a repair. So again, we've talked about most first-time women do tear when they have a baby. So what's going to happen is the provider is going to stitch up whatever tear you might have and kind of get things back to as best as they can at this point. With that being said, it's going to be so sensitive, and they will numb you up. They're going to use lidocaine, which also is a needle, so that part is going to hurt. But everything's just really, really sensitive, and it doesn't feel the greatest to get your repair done after you have a baby. So kind of prepare yourself for that. I feel like I even have patients that like the sponge of like just wiping the blood. They're like, ow.
Everything's just so sensitive.
Yeah.
I mean, you just pushed a human out of there.
So it's going to be.
Yeah.
But does it make it feel better? No. But just kind of prepare yourself like, yes, everything's done. And honestly, I have some people that are so distracted by baby, but it does still hurt. So I know how I would be. I would be crying, but you know.
I would think I would be too.
Use more
lidocaine. Yeah.
And
the whole bottle.
Right? Just tell them, guys, so you're going to feel like tugging, you're going to feel pressure, anything sharp is not okay. So kind of let them know if you're feeling sharp things.
And your provider should be checking in too. They should, be kind of testing it out and asking, and then just be honest with them. If you're feeling, again, that sharpness, tell them right then and there.
Exactly. So now your repair is done, and now we're going to go over the next kind of little bit of recovery here.
Yeah, so as Krista said, baby's up on your chest for skin to skin already. We are keeping baby there. We are trying to help breastfeed at this point if that's your plan. If you want a formula feed, we'll bring formula over, whatever it is you're wanting to do at that point. In the middle of all this, we're also doing assessments on you and baby, checking your vitals so frequently. So for a 2 hour straight, we are bugging you a ton, I'm not going to lie.
Yep.
On top of vitals, we are watching, again, we're pushing on that uterus to making sure that's staying firm, and we're watching your bleeding at the same time for mom.
Yep, so that's kind of the first full 2 hours of getting all those things done, kind of keeping baby skin to skin and get that feeding done like Kelsey said. So kind of all of that is like wrapped into happening all at the same time. And it goes by really quick. So you think that we're kind of bothersome for a little bit, which we are for your sake, but
you see a lot of our face.
I feel like those first 2 hours just fly by.
I think so too.
And then it's going to be about time for you to get up. We talked about this in our epidural episode as well. We never let patients get up by themselves after they have a baby. It doesn't matter if you have an epidural, if you're unmedicated, you just had a big fluid shift, a huge event. You probably didn't eat that much in the last however many hours, so you need to have somebody with you the first time that you get up. I always find this a great time to have the support person do skin to skin if that is their plan. But the nice thing about being unmedicated is you can get up right after that golden hour if that's what you want. If you want to get to the bathroom and clean up, you don't have to wait for your legs to get unnumb. Like you're just like, sweet, I want to get up, I want to get cleaned up, let's go.
Yeah.
And it's really nice. I feel like most patients like love that part of being unmedicated is that like they just don't have to sit there in bed and wait.
Yeah, I agree. Whenever you are feeling up to it, if you have to go to the bathroom, if you just need to like get out of bed, just make sure we're there.
Yeah, call us. Let us know that you're ready for us. And then it's time to kind of get up, get cleaned up, right? So we talked about that. I think it was in our 10th episode when we talked about postpartum vaginal stuff, and that kind of from that point all the way until the rest of your stay, we kind of run through and what going to the bathroom for the first time looks like and taking care of your bottom area. So you can definitely head over to that episode if you guys want to get a little more detailed about that scenario, because obviously it doesn't matter if you're medicated or unmedicated. From that point on, everything's the same.
Yep.
So head over to that episode, kind of listen to what that looks like, and then we also are planning an episode of birth preferences. So we do have a birth preferences sheet in our link tree that you guys can print out and fill out, just kind of an option if people want it. If you just want to look at it for ideas, that's great. So that's available, and we are going to have a whole episode kind of geared towards talking about birth preferences and just running through like, I don't know, things that are really, really important and things that maybe you didn't think of, and just kind of different options of what you want during your labor.
Yeah, just more education for you guys.
Exactly. Again, being prepared is the best thing that you can do for yourself going into having a baby and having labor. So that kind of wraps up this episode talking about low intervention. Next week we do have a surprise guest that will leave you hanging and not tell you who it is yet. But if low intervention is your thing, then I think you are going to want to tune into next week's episode where we can maybe learn a little bit more about that.
Yeah, please watch out for this episode. You guys, we were so excited. So we can't wait to release that. And as always, if you have any questions, send them our way. If we missed something, if there is something that you never thought of that worked out for your low intervention labor, tell us. We'll talk about it.
We would love to hear about it. So yeah, we appreciate you guys listening and tuning in, and we will see you again next week.
Thank you.